afternoon. It is October the 14th, 2021, Thursday, the day where the Dodgers play the Giants. We don't have vids on, so we can't have the Dodgers-Giants rivalry conversation today with a bunch of Midwesterners and East Coast refugees who really don't care about this West Coast thing. But anyway, I am Matthew Holt. It is THCBGang. I'm the founder and publisher of the healthcare blog at Boy on Twitter. And today, a small and mighty team, Kim Bellard, writer and THCB contributor, Deven McGraw, Chief Regulatory Officer at Citizen, and lots to talk about with Citizen since Deven has last been with us, and Michael Millenson, President of Health Quality Advisors. So we are it. How is everybody doing? That's right. You're supposed to smile and nod and wave appreciatively. Well, so let's do a quick around the horn because there's a ton going on. There's been a lot of money and transactions in my little world of digital health since last Thursday. And when I say a lot, I mean a hell of a lot. Billions and billions has been spent. So I'm going to talk about that. Michael and Kim, I'm sure I was going to say, and then we're going to we'll get into something that's happened in Deven's world very close to home since she was last with us. All right, Michael, what have you been up to the last week? What have you been up to?
Well, there have been a heck of a lot of transactions, and we will talk about that. It's kind of amazing. I feel a bit left out that nobody's offered me 6 or 7 figures, although occasionally I get offered 1 or 2 figures, that depending on if it's a good day. What I'm looking at is drugs, right? We have COVID-19, whether or not the boosters work. We have COVID-19, whether or not Moderna is actually going to let it be sold for anything less than the most profitable amount of money it can make to the rest of the world, which is coming coincidentally at a time when we're talking about drug pricing. And so we know that nobody would do any innovation if you took away even a nickel of their profits. What's fascinating, my favorite line of the week in regards to that is pharma, the trade group for the pharmaceutical industry, is objecting to the biased nature of the Kaiser Family Foundation poll on drug pricing and negotiating drug prices. And what was the biased nature of the question? The Kaiser Family Foundation went to people and said, the argument for these negotiating drug prices is that it will reduce drug prices. The argument against and make drugs more affordable. The argument against it is that it will hurt innovation. What do you think? And 83% of people said they favored negotiation before hearing the counter argument. And then after the counter argument, only 82% agreed. And only 6% said that drug companies need the high drug prices for innovation. Now, the pharma industry, on the other hand, prefers a question that said, if you were told that drug pricing negotiation would lead to less innovation, would you be in favor of it? That was their unbiased question that they preferred, in which case 65% of people said, no. Now, here's the really interesting twist. That unbiased question that they preferred, which was obviously very leading, was asked by Kaiser Family Foundation in June. The terrible question, which is not phrasing it the way they wanted to, was asked by Kaiser Family Foundation in September. So clearly, Kaiser Family Foundation is biased by moving to an unbiased question.
Well, it's good to see we got some both sidesism in the bias we got going on.
Yeah, so I thought that was fun. That accusing them of a straw man and not saying, so I believe their argument, and I understand this, is if you don't phrase a question saying that the consequence of something is what I think they'll be, you're biased. And I can understand that, because anybody who disagrees with what I think is going to happen must be biased in the wrong direction. Whereas if they understood any issue the way I understand it, they would agree with me and therefore they would be unbiased. So that's really my favorite public policy pronouncement.
Did the Kaiser Family Foundation run a question saying, if you were told correctly that a farmer spends 3 times on marketing what it spends on R&D, would you be upset if the government negotiated to reduce prices? I wonder what the answer to that one would be. Oh, well.
That's an amusing framing that they did not do, but yes.
I think we should have to run a survey monkey poll on this next time I do some. Yes. All right, Kim, what have you been up to? What are you looking at?
So in the last week, the state of Ohio passed a a bill banning vaccine mandates, and the city council of the town in which I live is trying to replicate the Texas law banning abortions and aiding and abetting an abortion. So for anyone who believes that what happens in Texas stays in Texas, that is not true.
On that very note, you may have noticed one of our friends and contributors, Casey Quinlan, had a podcast, a very personal experience of what it was like for her to get an abortion when she was 18 pre-Roe v. Wade. And, there's some really, really sobering stuff there. I don't know how much we'll dive into that. But yeah, I mean, it doesn't happen in Texas. And the Texas law has got, well, I should ask the lawyer on the panel, the Texas law has got stopped, right? For now, the federal judge.
I believe there's an injunction. I have not been, I've tried to keep up with it.
No, the last I knew, the Fifth Circuit struck down the injunction, and now it's being heard by the appeals court. Like today, they're hearing to see if they're going to do a full thing again or not.
I mean, it's
going to go to the Supreme Court.
It's obviously got to go to the Supreme Court. They actually got to argue it, and then we're going to see what happens.
They had like 2 days when they could do abortions again before the Texas Attorney General got his wish and got the.
Well, and my understanding is even during that 2-day period, there was so much uncertainty about it that people were like, no, we can't take that risk. We can't take the risk of being sued, basically. So
it's not a pretty.
And it's only a matter of time. I think there's 20 other states that already have their versions of the bill in the works.
Yeah, for sure. Texans didn't come up with this. I mean, there's an entire network of folks who have been, who have some very smart lawyers who have been working on what is a bulletproof statute that we can get through these legislatures that will pass constitutional scrutiny because there's no state action involved.
The organization that advised Texas on their law is advising our city council. So they are going down to the small level to try to get this done everywhere. It's just shocking.
They're all in favor of the right to life unless it involves being vaccinated against getting killed.
Right.
Or after you're actually born in general.
Control over your own bodies, unless you're a woman and it's abortion.
Although to be fair, and I don't want to the go around, this whole thing about it being anti-women and all the rest really bothers me, because if it was just all women agreed, 51% of the population plus whatever men agree. And it's simply the reason we keep on losing is we talk as if it's a given that all women agree with it. And there are plenty of anti-abortion, some of the most prominent anti-abortion activists are women. So, to simply frame it as, you see something at times, if men had abortions, maybe, but there's plenty of, unfortunately, or if you're thinking fortunately, it ain't that simple.
Well, but that's judging that issue, Michael, based on where the gender breakdown is in terms of who supports legislation like that, which is a completely different set of questions than a question of whether a law that targets a particular medical procedure that can only be performed on women is in itself misogynistic, anti-feminist, disproportionately impacts women. That's the lens through which I think they're looking at it. Not whether people who support abortion are predominantly men or women, or the other way around.
But Deven, and this is what I'm trying to wrap my head around, and it is a true credit to Donald Trump that he has managed to mix up everybody over everything, where you have Jewish supporters supporting a guy who likes Nazis, you have, people who are supposed to be in favor of let the meek inherit the earth, who support anti-religious guys. So I really want to credit Donald Trump's communication abilities, but leaving him aside on this, if you have women who believe that abortion is murder, and they're supporting a law that's targeting women, it's hard for me to disentangle that from gender gap, because would those women say it's misogynistic, or would they say it's just we're preserving life? I mean, I personally happen to agree with you, and people talk about privacy and government intervention, all the rest of that. What I struggle with is how can you call women who support this law anti-women? You know what I mean? But help me.
Can I give you Exhibit A, Margaret Thatcher?
Sure.
Of course, she
No,
was
look,
the
I
only man in the Tory party.
look, there are women who, a lot of times for religious reasons,
Right. That's what I'm talking
are
about.
supporting certain, are in support of these measures, but that doesn't change the fact that the measure itself, because it targets care for women, just and in terms of pregnancy takes two people, right?
Right.
Pregnancy takes two people. And for the most part, interventions around preventing or dealing with what happens after the event of two people, a man and a woman, or an egg and a sperm, if it's done through some sort of infertility procedure, is just disproportionately weighing on women versus men.
Yeah. No, I would agree with
numerous
that.
other ways that you could approach the issue of preventing unintended pregnancies, dealing with unintended pregnancies, dealing with genital issues in a fetus that that's all I'm saying. This is not to say that the political issue is gendered necessarily, but the approach to it is most decidedly gendered.
I think that's very true. I would agree with you. I guess all I'm saying is I want us to win more political battles and have more effective arguments for that. But I couldn't agree with you more.
I want to move us on, although I would say there was quite a funny thing I saw on YouTube, on Twitter, which was somebody argued with Charlie Kirk, the far right guy from Turning Point, saying, hold up a picture of a fetus. Is this a human? Is this already a human? And the guy, I'm trying, it's definitely human. He said, that's funny because it's a picture of a dolphin fetus. But anyway, there we go. All right, moving on. Deven, we haven't, come on, we've got to break the elephant in the room. You have not been on here since you became a member of a new company. So tell us what happened.
So Citizen was acquired by Mbta, the genetic medicine company, back in early September. So it was announced on Tuesday after Labor Day. But then of course, that's when the agreements were signed. It only took us another week to close. So I have been, so all of us from Citizen have become employees of Mbta Corporation, and we are operating the Citizen platform from within Mbta.
Fantastic. Congratulations. And it looked like from the outside, we were going to, before you got on, we were going to talk about, we were talking about you behind your back. It looked like a fantastic deal for the folks at Citizen.
Yes.
But also, Kim asked the obvious question, which is, why is this a great deal for Mbta? And I can never know. It's Mbta, not Mbta.
Mbta. Yeah.
Right?
Why is it a good deal for Mbta?
Tell us what they do exactly. I looked at the press release, but it's all sort of vague.
What they're doing and how you're fitting in.
So they are a leading genetic medicine company. I think they see that while genetics is a very important component of health, so is clinical data, so are patient-reported outcomes, so is other types of data. And if you want to essentially create healthcare solutions that are kind of a 360-degree view of the patient in an environment that the patients control that data, then you've got to go beyond genetics, and you've got to have a platform that engages patients directly and that also collects the other components of that data in addition to the genetic testing data. So it's sort of very consistent with a view of sort of being a major player in healthcare, being the health data platform in healthcare, and particularly the patient-controlled health data platform that they would need to expand beyond just the genetics piece. And that's what we bring to the table to them. I mean, we obviously have been focused on cancer and rare neurological diseases, but the idea is that we are going to scale to many other conditions and many more patients, including ones who are not sick.
Did you guys go looking for them, or did they come looking for you? I mean, were you each looking for other partners and that just worked out, or was that for some reason the connection between the two companies?
It's a good question. I'm not sure how they found out about us, given that we were kind of on the
Everybody
smallish
knows about
side.
you.
Clearly, they were watching THCBGang.
They were
saw you,
watching
they thought, "How do we
THCBGang,
get
that's
her?" They wanted to buy me and Michael's chat show, but apparently they run them around and got them out.
Well, we did a pilot together before the acquisition, just to sort of test to see if there were synergies and if the kinds of capabilities of the citizen platform were ones that were appealing for them. If in fact patients would be willing to share their data back with Mbta, and they, when asked, and they were. So it's obviously I think it's an incredibly symbiotic relationship, because we wanted to find a solution that would allow us to scale what we had built. We could see that we had come up with something that was incredibly valued, that patients really loved, and that had legs. But obviously, when you're a startup, you're constantly sort of looking for resources in order to make that, to make scaling possible. And so when Mbta first approached us and we first began the discussions after we had a successful pilot together, we were like, this is starting to really make sense, because they, to have a home within Mbta to do what we wanted to do, without having to continually raise money with a company that already agreed with us that patients own their own data, and patients should control their data, and patients should have choices about when their data are accessed, used, and shared. And so it felt like a very natural coming together, and then you're just arguing over numbers. So
Deven, what does a genetic medicine company mean? I mean, I don't think that something that you take with a little spoon and 2 droplets of a genetic medicine when you're sick, you give it to your kid. What does it mean? Are they a pharmaceutical company? Are they a services company?
No,
they
are a testing company, but they also do do some analytics on the data. They contribute regularly to ClinVar, the federal database of variations. They're constant. Genetic medicine is still really evolving. We may have mapped the entire human genome, but we don't necessarily know what variations are relevant,
absolutely,
what variations are significant. There's a lot of research that's yet to be done about, in order to facilitate precision medicine solutions. So when I say they're a genetic medicine company, like, they do more than just testing.
They're an analytics.
Counsel people on and run a number of programs in conjunction with patient advocacy organizations and some pharmaceutical companies, et cetera, some academic researchers. Like, they're really, on the front lines of, thinking about how do we expand genetic medicine in the US and across the world, so that people are getting the right treatments for their conditions.
That's great.
Or developing the right treatments.
That's really good. I did a white paper on the genetic medicine for Urban Institute a number of years back now. That's great to have the analytics and to have people who are really patient-centered. That's great.
So the one question I'll ask you, Deven, I know this is one for you and obviously your other investors, but we're in a world where, by the way, if you take this deal in isolation, just look at the numbers, right? It was announced as 325 million and then a bunch more in RSUs, another couple $100 million. So, assuming that all comes through, you're in about a $550 million deal, which not too shabby for a company that's 3 years old and
almost 4.
Nearly 4,
almost 4.
Raised,
almost 4
like
to the day. Yeah,
you raised like 25 million odd, or something, which doesn't sound terrible. But we're in a world in which, to go to my little point, is right. People are raising incredible amounts of money all day. There are $100 million rounds, $200 million rounds. Just last Friday, we had the first, I think, more than $1 billion single investment round in one company, which is devoted. I know it's a Medicare Advantage plan, but at the same day, we had we've seen $150 million rounds, things like Twin for Twin Health, which is another algorithmic testing company. Just in the last week, I remember there was a $300 million round for BetterUp, which is a mental health performance company. So you're seeing these enormous rounds. You must have been tempted, you and the management team, to go down that path and say, okay, can we go back and do a round that's really big and see if we can scale that way? Why? I mean, without sort of telling us the gory details, how did that choice did you guys make that choice?
Well, for any young company, any startup, you particularly after you've raised, you're sort of at the MVP stage, right? You sort of have this minimum product and you really want to scale it. What's the next step to take? And obviously the market is very favorable for people raising really large rounds. On the other hand, some of the expectations that come into play for a very young company when you raise that kind of money, when somebody's putting that kind of capital on the table, are extraordinary. Puts an extreme amount of pressure on a very new company, as opposed to, not that we're not going to have pressures to produce. I mean, we are a public company. We answer to our shareholders. We are going to scale this company and we are going to do very well. But the timing of when all that is expected to happen, it can be radically different when when a set of investors expects a return on their investment within a very short period of time, and what those expectations create for these small companies, I think, is something that you take into consideration when you are thinking about where you are in your own trajectory as a company, and what's going to allow you to scale in a way that is actually achievable. The other thing about taking a really large tranche of money and scaling on it is that you're doing it all yourself. You're not leveraging any other resources of the company. You have to hire all the engineers, you have to hire, all the support infrastructure. And when you find a good strategic partner with which you share a common vision, common goals, common commitments to patients and with respect to data, and they've got infrastructure, that, it just made sense for so many reasons. But the most important thing for all of us, it was what's going to allow us to keep doing what we're doing, but for more patients and better. And it was pretty clear that Mbta was absolutely the choice that was going to allow us to do that.
Are you picking up Mbta responsibilities too, or are you strictly still developing?
Yeah, that was going to be my question too.
I am. No, I am.
You gave yourself more work.
I am. I did actually. I have a new title. Actually, I was realizing that just before we got on. We're all still in the phase of kind of, bringing the two companies together and making ourselves more efficient and nestling in.
Tell us the title.
Well, it's interesting. They have more functional titles than sort of typical titles. So my title is lead of data governance and data stewardship, lead of data stewardship and data sharing for the Citizen platform. So it's still very citizen focused, but it's much more of a, it's actually a title that's much more consistent with the role that I was playing at Citizen. But I will also, but it's the Citizen platform within Mbta. So it's not just for Citizen anymore. It's for, kind of Mbta's data strategies writ large. So
if they ever hire an English major, if they're hired an English major, you could tell them you don't need a title that long. The word stewardship would cover sharing. On the other hand, people could remember it. On the other hand, you could have a committee of techies and they would find that this is too short a title, because you really want to have a title that covers everything that anybody on the committee can think of.
Well, I mean,
this is why they bought her company, not yours, Michael.
I know.
I definitely will get to spend more time doing policy advocacy.
That's great.
Which around interoperability, which is super exciting.
Add that into your title, really. Data sharing, data stewardship, and interoperability. You need more words. It's more important.
Or you have to come up with an acronym.
Stop bullying Deven about our title. I would just like to say, Deven, I think it's fantastic news. I think that Anil's vision, all the work you've done to help it, and and by the way, when you left DC and came out to Silicon Valley and tried to do this, not everybody has this kind of a good result. So it's like I was saying about as I'm talking about the Giants fans tonight. It's not every day you're in game. You're in the deciding game of the playoff that you get to that. So enjoy it. So
no, it's great. It's great. It's great stuff. It's
Thank
great
you.
stuff.
Thank you.
And
Thank you guys.
It'll be really good to have. I wrote a proposal back in 2001 to RWJ, Robert Johnson Foundation, saying the future of medicine is evidence-based medicine plus patients' preferences and values plus genetics. Those three are it. And they said, nah, go away.
Spot on. Send me the link to that paper. That's spot on, Michael.
And I'll find out, but because it has to be, because the health policy wonks, as you know, ignore the genetics because it's biology and that's not what they do. They do health insurance. The biology people don't think about the healthcare delivery system because they get NIH grants, which makes them morally superior. And none of them think about the patients because those are those people over there that we invite to an occasional meeting. But if you put together patient preferences and values, which is what you're doing with the technology, plus the genetics, plus the evidence, that's when you start to get where the future is. And for you to be able to do that with the clear commitment you all have to listening to patients, as opposed to patient engagement means patient compliance, but we don't use that word anymore. That's just awesome. And I'll look forward to all the good things you do.
Thank you. Thank you.
All right. Well, we're really excited for you, Deven, and for Neil, and for the whole team there at Citizen. It's going to be really interesting to see how that all plays out. And now let's move on in the call to in the chat today, the Yang today, to talk about a couple of things that happened this week. And I want to bring both of these massive deals up because I think it's super fascinating. So the two deals I want to focus on, which are somewhat interrelated and connected in terms of how it's all going, is the massive investment in Devoted, which was $1 billion, $1 billion, $1 billion, $2 at an $11-12 billion valuation, and Devoted is about the same size, a little bit smaller actually than Clover, which is currently trading in a market cap of $2 billion. So it shows you that some valuations given there for what the Park brothers are up to, which really exceeds, seem to be what the market. You actually could buy Clover, you could buy Clover, Oscar, and Bright Health for the valuation of Devoted right at the moment. Were such a transaction going to occur. And then just this morning, Walgreens paid over $5 billion, valuing the whole company around $15 billion for what it does known as VillageMD, which is sort of like a primary. In
my neck of the woods.
Your neck of the woods, right, which is a great result for Tim Bellard and the folks there, but is basically showing their determination to be thought of not just as a pharmacy anymore, but really to be a healthcare delivery system. And VillageMD obviously is going to have retail spots in Walgreens. They're going to open, I think Tim Bellard said at the conference Jess and I ran, that they're going to open as many new outlets is the wrong word, as many new clinics in Walgreens over the next 2 years as Starbucks did at the height of the expansion. It's like 2 a week. So they've got a lot of work to do. But nonetheless, that was already planned, and now this transaction's happened. So I guess I'd love some general commentary about ignoring the pricing for the moment, the amount of money, and whether it's how crazy it is, et cetera, et cetera. Ignoring all that part, are we seeing the kind of the conversation about how much is the healthcare system changing? Are we seeing this kind of alignment that we've been talking about starting to happen? Are we seeing a real change towards retail? Are we seeing a real change towards a new type of Medicare Advantage plan as opposed to what United and Humana have been doing for years and years? But don't forget, this is coming at a time when just recently, 10 days ago, right? Rich Gilfillan, have I got his name wrong again? And Don Berwick wrote a piece about how Medicare Advantage is just this thing called the Medicare money machine. It's all about risk adjustment. There's no real, better care coming in there. So what do you think? Perhaps Kim, I can go to you. What do you think these two deals indicate, if anything, about how much the system is changing or going to change?
I have to admit, I don't follow deals the way that you do. And I have to admit, I didn't even know Devoted Health before the deal came. So that shows how far behind I am on this stuff. I wonder about all these people opening up all these properties and stuff. I'm wondering, where are they going to get all the people to staff them? I mean, there's only a finite number of NPs in the world, and even nurses are in short supply everywhere. So I feel like they're saying they're not actually recognizing what's happened to our healthcare system, and they should be going virtual first, and doing those kind of platforms. So I don't think that they're really yet reinventing everything. On the other hand, all the digital health stuff that you and Jess cover so well, I think that's kind of over fraught. I mean, I think there are a lot of people, putting money in with no hope of, making that money back in any realistic way. So we're in a period of big transition, but I don't think we've got the model that we're going to get to yet.
So Best Buy also bought Current Health earlier this week, right?
Yes, which is remote patient monitoring.
Yeah, I agree with Kim. Buying and staffing one thing. Village MD has been very well run. I actually know the CEO, one of the senior guys, and the scalability is tough. And Walgreens has messed things up in its previous Boots merger, and I'm going to go to Walgreens tomorrow for my flu shot. Would I want to go into a Walgreens to see a doctor? Not so much. And I've been into the modern ones. For my COVID one, I went into the one where they haven't renovated it, and the one where they have the nice music, and it's still a Walgreens. It'll be interesting. The word I use to describe a lot of these deals is disintermediation, which is what happened in a lot of other sectors of healthcare, right? And so the traditional care system is being disintermediated in some ways, where you can take your primary care here, your mental health here, all other ways. And they're joining in some ways when they can, but the holistic system is being broken into pieces and disintermediated and bought for huge amounts of money. And to a certain extent, this is going to be advantageous to consumers. And to a certain extent, as Deven noted earlier, the people who are investing this amount of money want to make a lot more money back from their investment a lot sooner. And so, you sort of have to ask yourself about this. But the technology is driving it. Now, healthcare has a long and glorious history of every technological innovation being promised to be cost saving. And not so much. It just becomes additive. So we shall see, but the disintermediation is real. The disintermediation is unprecedented, truly. And when you add in not just the kind of things that Walgreens is doing or Best Buy is doing, and you talk about the kinds of things that Deven's doing with Citizen and Mbta, and you start to give people control of their data, not just a different place to park their cars while they see a doctor or park their camera while they see a doctor. It really has the potential for enormous change. But we shall see. I have, as I've said before on the show, I have a unbroken history of being overly optimistic about transformation.
Well, two of the data points, if memory serves correctly, didn't CVS just recently announce that they're going to open up like 500 more clinics in stores?
They're absolutely in the game as well. And they didn't invite other companies to do it, but yes.
Yesterday, I believe Anthem announced that they have a president of digital platforms. Like, Anthem has a digital platform. I missed that one too. Like, oh, okay.
Yeah, he got a press release, and my buddy, who was the head of, who went from being the head of Bryony Wynn, who went from being the head of strategy to being the head of provider solutions, didn't get a press release. I suggested a couple of the Anthem PR people should be fired.
Kim,
but anyway,
Kim, you must have missed the press release about the 3D printing of doctors.
I was stuck on the 3D printing of chicken that I wrote about a couple of weeks ago. I'm still struggling with that. Struggling with that.
That's how that staffing issue is going to be solved. So really,
we're gonna eat the doctors and use the chicken as doctors. I don't know. It's Mbta.
Oh Lord,
Deven. I don't know how we're gonna.
Well,
help, Deven, help.
It's been a while since I've been on, but at some point, at numerous points throughout this pandemic, we've had kind of robust discussions on these calls about telehealth versus non-telehealth, and I think telehealth platforms moving more towards the technology is important, and it's something that we need to make sure gets preserved. But you can't give yourself a flu shot. And when you're sick, there's only sometimes a limited ability for you to be actually accurately diagnosed and treated over the phone or over a video call. So bricks and mortar is still going to be needed. And I do think there's still, I love the sort of easy in and easy out of some of these kind of, I don't want to call them pop-up clinics because that's not the right way to put it, but minute clinics, what Walmart is doing, because it's so easy. For a lot of people, getting an appointment with their primary care physician is like pulling their hair out. It's hard. And maybe this is the way we all also can start spreading some of the love around sort of basic care to professionals like nurse practitioners and physician's assistants and things of that nature that often are maybe more used in some of these environments than they might be in a traditional office practice. Doesn't solve the problem that we clearly have with capacity around workforce. And we got to get more kids into medical school, and maybe we've got to have, programs that are geared toward getting them out and steering them into primary care or preventive practices and getting them out sooner rather than, the sort of traditional hierarchy of medical education. Now I'm totally straying into territory I don't know anything about. But the fact that we have those supply problems does not mean that there's not value toward creating brick and mortar facilities that are easier for people to access.
Yeah, I'd agree completely. I agree with that. There is also something going on in terms of people who've received money in the telehealth world, figuring out how to get into that. So one tiny example of that is Roe, which is raised $500 million to sell its very limited number of pills, bought a phlebotomy company, sort of a phlebotomy company, and actually yesterday Andreessen Horowitz invested in like $30 million into a company called Sprinter Health, which is going to send people to your home either to take blood draws or to do COVID tests. I have a look at it and do a tweet stream because it seems to me I can't figure out.
And that's the disintermediation again. And then the problem is going to be is how we coordinate all this, right? So the data says it helps to have a continuity of a medical relationship. Now, I saw one doctor at my CVS, I saw my primary care doctor once, I saw this one and that one. We all know how good the system is at sharing information. Right. And hey,
Deven's fixing it. It's a new job title.
Give it to the patient. The patient will always have it. All of my care, if I've got that data, it doesn't matter who sees me. Here it is.
I think that's a good aspirational kind of thing.
Not you haven't sold Michael yet, I think.
I'm in favor of it in theory. It's just in terms of us executing on that and on people doing things with the data. I mean, it's difficult. I have no doubt that this is disrupting the traditional care system. We shall see, how the pieces settle out, right? Sure. And by the way, all the people who thought they were disrupting health insurance, when I see people like CVS and buying is all the health insurance companies at any time, high deductible health plans or anything else came along, their assets were disrupted from 20 billion to 10 billion, and they bought everybody anyway and shut them down if they were too disruptive or whatever. So I do not underestimate the ability of massive health systems to control things in the end. But right now, it's some good disruption going on.
Well, I argue, we've also got a couple of things on here, right? Because there is essentially there's a lightweight primary care, which is what's been offered. So to this point, when you start talking about, opening village MDs the way they currently operate, which are real comprehensive, primary care, multi-specialty specialty. Yeah. In some cases that's different. But when you talk about, the urgent care clinics or the walk-in stuff, that's stuff that is in general, like most telehealth to this point, been episodic, right? So basically it's care for healthy people who occasionally, show up because in my case, my kid fell off my shoulders in the swimming pool and cut his chin, needed to go to urgent care, and then the urgent care was closed. He went over to the ER, and I got a $4,000 bill. I drove to one to urgent care, I got a $1,500 bill, whatever. But it's that kind of stuff, like it's rashes and the UTIs and all that kind of stuff, and that probably can be handled fairly well. And you probably don't need too much of the way of going to people's houses and doing blood draws and doing intensive stuff there. But as soon as you get into the world of chronically ill, sick people, then we've got a battle kind of between the capitated medical groups who are growing. Now we're all publicly traded, but not so much more medical, but they bought Iora, right. Oak Street Health, of course, now Kano, Shenmed, all these guys, not to mention the ones that Optimus bought, because they bought a whole stack of them. United Health Group's bought the ones in Southern California. They just bought a big one in Boston. They have probably more, and Humana is doing the same thing. And it's not like the old incumbents don't think about this stuff, but they're thinking about, the old Friendly Hills model from 1993. Can you put a capitated group and manage a Medicare Advantage population, or can you manage a commercial population? Scott Street with Crossover Health doing the same sort of thing with Amazon. And then, you've got managing of chronic care, and then you've got obviously the old world of the systems we all know and love, whether it's Advocate Aurora in your part of the woods, or Sutter and and Dignity and where Deven and I live, who have been doing it the other way around. They've been making their money on fee for service, high ticket items in the hospital. And then there's one last group, right, which is it's very small, but you're just starting to see people building vertical online without much offline stuff for particular disease states. There's a couple in diabetes, there's a couple in heart conditions. I'm literally running into them. There was one for thyroid care. There's a bunch of them obviously in mental health. Whereas, can we manage this slice of you, a person who probably has this as your major health issue, just in that one arena? And it's starting to pick people off. And there's also some which are done culturally, right? There's a whole bunch.
And who pays for it?
They're all trying to figure this out, right? Is it paid for by the employer? Is it paid for by contracting out with that, getting on the health plans, becoming just another provider group to the health plan that gets on there, gets that number? Or do you figure out that you're doing something completely different and going to consumers, right? So to me, it's all in flux. That does seem, all of it, whoever you are, seems to be, as Kim pointed out, runs headlong to the fact that we have fewer nurses than we used to. Doctors are still not enough primary care doctors, not enough NPs. We haven't successfully replaced them with AI yet. We're going to get better at doing that. There's a long way to go here, but it just seems to me that when it was 5, 8, 10 years ago, a little bit of venture capital going to a little bit of this stuff, and that's one thing. When you've actually got Walgreens saying we're spending $5 billion and run this thing out, and we're going to do primary care, to me that starts to be a major player in those markets where there's a Walgreens, which I'm sorry, I can see it everywhere.
So what's the profit margin on primary care, Matthew?
Well, this is another interesting point. So go back to the company which I talked about.
Or everybody's going to have to pick up a pack of gum and a soft drink on the way back to the primary care office.
The profit margin of primary care, the only place that exists, right, is either going back to the devoted, not the devoted because they claim they don't do this, but to the rest of the Medicare Advantage, somewhere getting the government to pay you more per enrollee because you adjust their risk factor, or you take it out the height of the local hospital and specialist, you reduce those ER visits, you reduce those hospital inpatient. We've heard this story for many years. Kim, you must have heard the story since you started in healthcare, and it's still we haven't shown
Michael's comment. So I remember 25 years ago negotiating with a pharmacy chain, which by the way no longer exists, and they said we don't really care what the pharmacy rates are because we don't make any money on that. What we care about is the stuff between the pharmacy and the front. That's where we're going to make all of our money. So you're exactly right. They want to get people in the store and sell them other stuff.
But you can do that for a number of different ways. By the time you've made the commitment that Walgreens has made and CVS has made, you've got to be thinking about we're now not just a pharmacy store making money on greeting cards and high-priced and sugary drinks or whatever else they sell. But we've got to also be thinking about making money on the healthcare piece. And the only way I see you can do it in primary care is to go at some level of risk and take it out.
Because otherwise you can't. But I went to a conference of urgent care centers a number of years ago, and we talked about it being usually staffed by nurse practitioners, et cetera, et cetera. And a nurse practitioner there stood up and said, well, I did this for my health system or whatever. And the problem is that a nurse practitioner who's experienced knows what she can do and what she can't do. But when there's a shortage, you end up, staffing this with somebody who's right out of NP, certification. And that's a very different thing to know what to refer, what they can do and what they can't. And one wonders about, some of the stuff with what doctor are you getting, right? And that'll be interesting to see down the road.
Well, I would ask two questions. One, I'm curious, has anyone done a deep dive on the CVS and Aetna merger to see, has it actually benefited both those sides? I don't really know if they had to do it all over again today, would they? Has it really helped? And the second is, again, I don't know about you guys, but where I live, most of the doctors are owned by hospitals. So what would stop hospitals from taking full cap, as most of them were wanting to do 30 years ago? So if we want to control costs, they have the ability to do it today. All the high costs are in them. So why aren't they capitating?
But right now, it's the high cost and the high profit from the stuff that you'd have to get rid of if you got capitated, right? And that's always been the problem with hospitals doing it. If you look at so there was an interesting article written by a bunch of people from Eldaid and Bob Kocher, right? One of the venture backers of Eldaid. It wasn't Farzad Mostashari, it was a couple of the other team members there. And they were basically complaining the same way that Don Berwick and Rich Gaffilan are about Medicare risk adjustment factor, making it very profitable to do Medicare risk without the ACO program, the medical shared savings program of the ACOs, getting a similar kind of
Medicare Advantage
against, because the way the formulas worked was that if you were a big enough part of an ACO, and if your ACO was a big enough part of a rural area and you reduce costs, it actually reduced the average cost in that area. And so when you came around to get your next year's payment, you actually you were ratcheted down, not ratcheted up, and they went in with the risk factor adjustment and stuff that the ACOs. But the last thing is, if you look at Farzad Mostashari when he talks about this and is always promoting the studies which look good for Eldaid, it is true that the physician-based ACOs who don't have a hospital infrastructure have been saving more money and doing better than the hospital-based ones, which is logical, because hospital guys in the end, if you was on here, would say hospitals like filling hospital beds, right?
And Matthew, I did a study with some colleagues at the Brigham and David Muhlstein at 11 Everything. We visited what we called leaders in being patient-centered by ACOs. And we said, who's doing real patient-centered stuff by ACOs? And one of them, in fact, was down in rural Texas, the Rio Grande Valley. And we visited some of the hospital ones. And what is not adjusted when people say this isn't working, a hospital can have an ACO, but it can be like, 15% of its patient base, right? So they really don't try to reduce, they don't put anything into it. So the reason the doctors do it is the doctor group we talked to, they took out second mortgages. It is their money. And the other doctors in the group were like, it was IPA, it was doctors they knew. And they basically said to these guys they knew who'd been making money on fee for service, that's great, but this is our money on this. And either you toe the line and do things or you're out, right? But if you do, we're going to make money because the incentives are aligned. And that's what we don't do in the rest of care. And doctors can tell other doctors, sorry, this is BS, you're out. But when hospital administrators do it, it's about how do you get rid of a guy and you're biased, right? And that's part of the issue here of doing this. And the Village MD will be interesting to see how they do this. By the way, the reason that the Medicare HMO plans, et cetera, have a better payment mechanism is when you have the political clout to get people to call it Medicare Advantage, you also have the political clout to get the kind of rates that really are, how can I put this? They're just as supportive of innovation as paying high prices for drugs are of innovation. They're really pro-patient and important to pay Medicare Advantage plans and pharmaceutical companies as much money as possible because that's what patients need.
Oh, that's the George Costanza stand up and we'll go to the room when you're done with the history. All right. Okay. We have any other comments on that one? Was just for the last couple of minutes. I want to go back to where you started, Michael, which is and you just raised again, which is the drug issue about kind of and this is where Kim beat me up the last time you were on about what was in the infrastructure bill and the other stuff. And
I remember that last time I was on, yeah.
So I was beaten up because I foolishly thought that the caregiving part was in the 3.5 trillion bill, but I was told it's not anybody's bill now. But we do have dental extension for Medicare and hearing aids, a bunch of other stuff in there. We don't seem to have got. We were promised, infrastructure was going to pass the House, and this other bill was going to go with it a couple of weeks back, and it seems to have stalled. And I'm seeing a lot of articles politically saying, "Oh, Biden's approval rating is down, and this is working now." Post the Afghanistan thing, things aren't looking as good. We're hearing rumblings about Trump holding rallies, thinking about running, running with 2024, and Steve Bannon is avoiding the congressional subpoenas. Yeah, where do you think we are on significant change or significant legislation passing? Do we have a sense that there's any change there?
Well, I thought it was interesting that Nancy Pelosi put out a statement, I think it was earlier this week, saying that she's talked to her members and they feel it's better that they do fewer things better. And then the next afternoon, she was forced to say, well, maybe not. Maybe we can do everything. So they still don't have agreement on what to do. But the Times did a survey of some sort of experts about what were the most important things in the Build Back Better bill to do. And the thing that came in first was universal pre-K, followed by the child tax care credit. They didn't talk at all about the Medicare or the drug pricing stuff. They were only focused on the family stuff. But that is the kind of exercise that they're going to need to do, because they're not going to do them all. And they haven't gotten their heads around that. They're not going to do dental and vision. I'm sorry. It's not going to get in the final bill.
Nor should it, by the way. I mean, the whole thing is the whole thing
is people in Medicare like you don't have teeth anymore. Is that right?
Larry Levitt wrote a piece today, I think, that said that the most important thing that they could do and should do is Medicaid expansion to get those 12 states, get coverage for those people. That's going to have the biggest impact on people. And nobody's talking about that.
Absolutely. Well, it's because poor people don't vote enough.
That's exactly right.
And it's just ridiculous. The whole
because when they try to vote, they run up against barriers that are now legal to put in place.
Especially in the states where most of them are, Texas and
That's
Florida.
Exactly right. But even when it benefits their constituents, these folks are against stuff, the poor white population. But yeah, Medicaid expansion more. I mean, the other stuff, you just expand any Medicare benefit and you get gaming and you get price rises and the whole thing we've learned is that it's just an open door to all sorts of crazy stuff.
If you have modest income, AARP will sell you a dental and a vision product. It's cheap, it's like, $50 or something for both of them. So that's not the problem.
No. And the Medicare expansion, if you look at that, you're putting in the people with a lower cost anyway. I mean, the whole thing is based on fantasy as opposed to analysis. Give kids education, give kids daycare, give poor people health care. So
why have we not heard enough about what's in the? I mean, we've got stuck on 3.5 trillion and following Christian.
Over 10 years, by the way, over 10 years. It's not. Yeah, but nobody says that. It's ridiculous.
I did hear one proposal, which is you just do the same thing, but do it for 5 years, and don't let it run out and kick the can down the road. You hear all that stuff. But
and curiously, the 3.5 is talked about as though it's a straight out to the deficit. There's not a lot of talk about, well, are there offsetting revenues to cover that?
Exactly.
Why is
one of them is negotiating drug pricing. Isn't that the biggest single one?
But it's never in there, and so it's an easy bad talking point. And the Democrats, they put in accountable care organizations. The Republicans give you Medicare Advantage.
So one side gives you an advantage, the other one makes you accountable. Yeah, I mean, a lot of this is like you turn Medicare risk into Medicare Advantage. It sounds like a great move. Yeah, I mean, what's the over/under here? I should ask you all. Are the Giants going to win tonight, and are the Democrats going to pass the bill? Both of them seem to have the odds stacked against them.
I'm nervous about both. Good Lord.
The Dodgers.
So I saw you're an Orioles fan. I guess you.
No, well, so I'm a Nats fan, but I don't live in Washington. I haven't abandoned my prior sports teams, but I live here now, so of course I'm rooting for the Giants. Come on.
Well, the Giants and the Dodgers have been playing for 133 years. It's pretty amazing.
Well, what's amazing is that this year, if you count they were one game apart, having both broken the franchise.
It's crazy.
Wins. If you count the wild card game, the two games they both played 109. They have 109 wins. One of them is going to have 110 wins.
Right. And the other sad thing is that it's very difficult to root against any of them. Both of them are great teams.
Oh, no, it's not that hard
against the Dodgers. They're like
Dodgers.
No. It's not like rooting against the Astros I mean, the Astros,
Anyone can root against them because they're a bunch of
right. The Astros are easy to hate. You can root against the New York Yankees for their zillion payroll. Well, it's true the Dodgers had that crazy payroll.
Dodgers have a crazy payroll stacked with all stars. They have a bunch of terrible
That's
people.
true. You're right.
They have like a pro-Trumper reliever.
How much is the Dodgers payroll? Any idea?
It's a lot more than the Giants. I don't know. I forget how much it's not as much as the Yankees or the Red Sox, but
but you see, coming from Chicago, I have a sympathy for rooting for the most miserable city that has nothing else to recommend it. So like you have to like root for Milwaukee. Maybe. So therefore, Cleveland, Milwaukee. Whereas Los Angeles and San Francisco, if their baseball team loses, if their football team loses, who cares? It's nice weather. It's a great city. You go out. Right? Whereas if you're the Green Bay Packers, this is your life.
Yeah.
So,
all right. I did ask 2 questions there, by the way. We got lost on the Giants Dodgers, which will. But what about the some level of infrastructure combo bill? Do you think? I mean, it sounds to me they've got to be able to get something done.
Well, they have to get something done because that's the only way they're going to pass the debt ceiling and the funding of the government past December. So I think all that's going to get stuck into some reconciliation bill. So they have to find some sort of compromise.
Well, the question is whether they've passed 2 bills or 1. Deven,
well, the infrastructure bill only needs a House approval.
Right. That one, they got one. They're trying to do the larger one otherwise. Well, not infrastructure. Deven, do you think they'll get the other one too?
Yeah, that's hard for me to. Kim says yes. I'll go with that. I haven't honestly been following the debate.
Deven's had this other busy thing.
I think they've got to get. She's
been doing her own infrastructure bill.
I think they've got to get both to have something to say, that we didn't, we failed to cook the football, but you never know. I mean, it could be as simple as moving the capital from, Washington D.C. to West Virginia. It could be.
Is that in the bill?
Not Arizona.
It will be. It will be.
What they have to do to get it.
They'll move it to Kentucky to get Mitch's vote.
Yeah.
Oh, well.
I personally
don't
believe
think they're getting that no matter how hard they try.
I personally believe we should make Mitch majority leader. Just make him the offer.
He's better than Schumer. I don't like Mitch, but he's better than Schumer at what he does.
Well, you remember that when
it's an easier job though.
Right. Senator Byrd of West Virginia would move everything out of Washington to West Virginia. And, you never.
And by the way, let's be clear, the West Virginians and parts of Ohio and parts of North America and stuff, they're the ones that need infrastructure.
Absolutely.
They need broadband, they need to get all the stuff we're talking about.
Have you seen that Marjorie Taylor Greene is doing this faux vote about succession, having the red states just succeed? I'm like, yeah, we'll take our tax dollars and you go off and do your own thing. Let's see how that works out for you.
That would not be pleasant, I think. We'll see how it goes. All right. We've discussed, we now devolved into civil war. So before we get there, let's have a quick go around the horn and think, what are we looking for? We have a minute left. What are we expecting the next couple of weeks? I will start with you, Deven.
So I saw this morning that Rob Calif has been nominated to be the head of the FDA once again.
Oh, I didn't see that.
Commissioner.
Ah, great.
So I'm super excited about that. And we'll look forward to hopefully swift confirmation, because it's not good that agency has not had a political leader now for almost a year.
But basically, this is a trade. It's like the Dodgers, traded whatever for they traded Amy Abernathy from the FDA to
Verily's trading him back.
I thought she was going to get that job. I was very surprised she didn't.
Yeah, obviously, I mean, I don't know that any of us is privy to the inside discussions on that, but Rob was a great FDA commissioner when he served. So this is good news in my view.
Fantastic.
So,
all right, Kim.
Well, now that William Shatner's been to space, I think it's essential that Mark Hamill and Harrison Ford get sent to space so we can even out the Star Trek, Star Wars thing.
That is fine. By the way, I can make a bridge to healthcare there, because Ina Sawyer, actually it's my orthopedic consultant as well as a surgeon, as well as a person leading San Francisco, was leading the Center for Digital Health at San Francisco for many years, and now she runs the translational space medicine program. She's been telling me the stuff that happens in space is very important for what happens down here.
Well, when I saw Shatner coming down those stairs, I was sure he was going to need healthcare very soon. He looked pretty bad coming down the stairs.
All right, Michael.
Well, I've heard of Village MD and Walgreens, but I predict that there will be more acquisitions of companies I've never heard of by other companies I've never heard of for more money than I could ever imagine.
I think not only is that accurate, that's already happened, because Walgreens not only bought Village MD, they bought a big chunk of a company called CareCentrix, which does sort of home care and stuff as well. So there is a ton of stuff going on. My prediction is that by the time you see me next week, I will have been to the health conference in Boston. First big sort of conference back to the digital health world. And my prediction is my liver will be in much worse shape by Wednesday than it is now. And with that, I will want to thank all my guests. I'll show you who they were. If I can hit the right button here. Entertaining you and enjoying themselves today have been, hang on, that one. There's a weird thing happening with Zoom, which I have to fix at some point. Which is, there we go. Hopefully you can all see this to screen now. On the THCB gang today, we have had Kim Bellard from the wilds of Cincinnati in the Midwest, Michael Millenson from the non-successful sports town of Chicago, and Deven McGraw, fair weather Giants gang, fair weather Giants fan, having left the Nationals, who gave their best player, by the way, to the Dodgers.
Two best players.
Two best players, yes, I'm going away to the Dodgers. And who will we'll be seeing how it works out tonight. I'm Matthew Holt. We will be back October the 21st, same time, same place, 1 p.m. Pacific, 4 p.m. Eastern, with another THCB gang. Until now, thank you very much for watching or listening on the podcast.